Good afternoon, everyone, and welcome back to Track 2, Rare Activism. Thanks to Shire for hosting this afternoon's lunch. I'm Nathan Davis, and I will be your track host for these afternoon sessions. As a reminder, I would like to welcome those of you joining remotely through the live stream, and remember to download our mobile app to use some of our highlighted features like live Q&A. You can post questions, and then I'll read them at the end. You can do that in-house, too. We are joined this afternoon by Steve Roberts, Chief Scientific Officer at Tuberous Sclerosis Alliance, and Jonathan Thomas, Chairman of California Institute for Regenerative Medicine, who will walk us through funding sources you may not have heard of, funding and collaboration opportunities with diverse federal and state agencies.
Thanks, Nathan, and thanks for the opportunity to be here and share some thoughts and ideas. And we look forward to having a good discussion with lots of questions from you at the end of both of the talks. So for those of you who happen to be in the room for the session right before lunch, I was up here then, and about the first three slides, which are just introductory to where I'm coming from, will be very familiar to you, but everything else will be different. So to give you a little bit of background from where my story is coming from, tell you a little about tuberous sclerosis complex. It's a rare genetic disorder. It's characterized by abnormal growth of cells that can lead to non-malignant tumors in various organs of the body, including the brain, the kidney, the skin, the heart, the face, and many other places. TSC has an incidence of about 1 in 6,000 live births, and we estimate that there are about 50,000 people in the US that have tuberous sclerosis complex, which would extrapolate to about 1 million people worldwide. So even though it's rare, it's certainly not as rare as many of the disorders that I know are represented at this conference today. One of the interesting things about TSC is that no two people are affected in the same way, and not even identical twins. And there's some genetic explanation for why that happens. That doesn't really help us find a better way to treat it yet, but hopefully it will. And it's also very frustrating to be able to give guidance to parents of very young children who have a diagnosis and not be able to tell them what path their child is more likely to take. Two of the major features of TSC, in addition to the tumors, are epilepsy and autism. About 85% of people with TSC experience epilepsy, and 2/3 of those develop that in the first year of life. So it's a very early onset, and that early onset epilepsy, if not well controlled, can lead to cognitive and developmental delay that can lead to a lifetime of need for care. The TS Alliance has been around since 1974. So the TS Alliance was founded here in Southern California by 4 mothers who got together and wanted to make a difference. And ever since then, in one way or another, we've been dedicated to our mission of finding a cure for tuberous sclerosis complex while improving the lives of those affected. And we do that in 3 major ways. One way is that we develop programs for support and education of people affected by the disease. We have a phone number they can call, people who get a new diagnosis or a suspected diagnosis, have somebody to talk through the issues. At the same token, people who have been living with it for 40 and 50 years can also call the office, and they may have new questions that we can help them with. We also sponsor research, so we encourage and we drive and we advocate for research, and that's what a lot of the rest of the talk will be focused on. And then we work on educating both the public and the professionals about TSC to get the word out. As you know, with any rare disease, it's very common for it to be misdiagnosed or undiagnosed for too long a period of time. And when such severe things can happen in early infancy, that can be really wasted time that makes a big impact. So the more awareness we can work on, the better. To give you a picture of the funders of TSC, there are really 3 major funders of TSC research in the US. The NIH, represented by the green bars, the Tuberous Sclerosis Complex Research Program at the Department of Defense, represented by the red bars, and the TS Alliance, represented by the blue. And so you can see we fund a very small part of the overall research picture, and you've probably heard of the NIH, and the topic of this forum is really, what about funding sources that you might not have heard about? And so I'm going to take the tack of talking about, certainly about the Department of Defense program, because you might not have heard of that, but even more so focus some on the NIH and opportunities at the NIH other than just their grant program that you might not have heard about. So one of the things that is a big part of what we do is advocating for TSC research. So one way that we do that is by meeting with NIH staff at least once a year. And quite frequently, we're meeting one-on-one with the leadership of the institute. So we very commonly meet with the director of several of the institutes at the NIH. As you'll see later, the TSC affects so many different organ systems that we interact with 9 different institutes at the NIH. And so I would say we meet directly with the directors of probably 4 or 5 of those institutes every year to make sure they're aware of what we're doing, to make sure we're aware of new programs they might have to offer that we can communicate to our scientists and keep that communication going. We meet regularly with CDC and FDA staff. We meet annually with CDC folks who are involved in the developmental disabilities program there. Again, it's sharing information. What's changed since the last time we talked? Are there any CDC programs that TSC might be able to take advantage of? We know you don't have special funding for TSC, but how could we leverage things that you might be doing that are related? And the autism area is one of those ways. Autism has a pretty good financial support from Congress at the CDC. And so we've talked to them quite a bit about things that might be able to be learned about TSC through their autism program. And then there's grassroots advocacy, advocating directly to legislators for funding. We do a little bit of that on the state level, and I'm going to save any of that until the Q&A because I think John has a really nice story to tell about a very specific approach of state funding. But on the federal level, we have a March on the Hill every March to advocate for continued congressional support for that tuberous sclerosis complex research program. So the TSCRP was started in 2002, was the first year that it was funded. And it was really through a relationship of a grandfather of children, a grandfather of twins with TSC, who knew one of the representatives on the Defense Appropriations Committee and was able to get a line item added in to a number of other congressionally directed medical research programs, starting one for TSC. And so that's an example of how this direct advocacy through relationships can help get things started. Now we have to keep advocating that stay in there, right? And so making sure the House members and it's the House that writes these line items in there in this case, make sure the House members are aware of the importance, to make sure they understand how this research is different than what's funded by NIH, how we all work together, the NIH, the DoD, the Department of Defense, and the TS Alliance, and we talk to each other about the different types of things we're funding so that we're not duplicative, and we each play to our own strengths. With the TSCRP, it's based very similarly to the NIH. It's based on grant applications and peer review, but a really big difference here is that consumers are included in the peer review. So there are individuals nominated by the TS Alliance to the Department of Defense. They actually make the decision then on who participates, but there are parents of children with TSC, there are adults who have TSC who are on the panels who also help evaluate and evaluate proposals for funding, but more importantly, set the priorities for funding for the next year and the call for proposals. I do want to mention, because if you haven't heard of congressionally directed medical research programs before, most of them are very disease specific, but there are a couple, like the Defense Medical Research and Development Program and the peer-reviewed medical program, that are much broader in scope. And those might be opportunities for your researchers to consider looking there. Perhaps this is another opportunity, another place to look for grant funding that is separate from the NIH. Oh, sorry, I clicked too quick. So, and then back to the NIH and the trans-NIH meetings. This is different than the one-on-one meetings with the individual directors. That's where we get to know the 9 institutes, and get that relationship going. At the trans-NIH meeting, the concept is we get program officers from across all 9 of those institutes in the same room at the same time, together with staff from the TS Alliance and the scientific staff from the Department of Defense's Tuberous Sclerosis Complex Research Program. So all of us are sitting around the table for a day with an agenda, not just sitting there, and moving forward to understand what are each of our groups doing, what kinds of things are we funding now, what are the priorities for future funding, making sure that we are not doing the same things, but that we're doing what we're best at. And one very specific example of this was our 2014 Trans NIH meeting. We were sitting around the table and realized that it had been more than 10 years since the NIH had really evaluated a strategic research plan for TSC. Well, 10 years is a long time. A lot had been learned since then, connecting the TSC1 and 2 genes into the mTOR pathway. This had led to development of mTOR inhibitors. They actually have 2 indications for treating TSC, far from curing, but making a difference in people's lives. So we needed to really update that research strategy. What's next? What are we going to do in the next 5 to 10 years? And wouldn't it be better if we did this together than anybody doing it individually? And so the DoD, the TS Alliance, and the NIH worked together to plan a workshop. We got academic investigators who are really leaders, thought leaders in the TSC field to put together some working groups who could work on some very specific topics. We included people who were TSC researchers and clinicians, but we also included some who were a little outside the field to bring in some new ideas, and we included some pharma folks as well. And this led to, I guess I'll back up, this led to, on the right, some new TS Alliance programs. So there were a number of recommendations. These have been published, and they're out there in the literature if you want to see all the recommendations. But 2 of them, the TS Alliance said, sorry, my fault, said, I think we can start. I think we can take the lead on this and get them going. And so at the onset of that workshop, the TS Alliance had 3 collaborative research programs. We had the research grants where we're funding young investigators, postdoctoral fellows, try to get new research started. We had a natural history database that was a collaboration across 18 TSC clinics that we funded for the collection of natural history data on TSC. And we had a clinical research consortium where we provided some seed funding, but these investigators were now doing NIH-funded clinical studies, but working very closely together to do it. So the 2 that we added were first a biosample repository. Coming out of that workshop, we realized one of the key things about TSC that researchers needed to understand or help us understand was why is this disease so different from person to person? As I mentioned, we kind of have a genetic explanation for it, but that doesn't help us move from understanding at a very basic level the genetics and moving that into what can we do to influence this, to either give parents of young children the right, the best information we can to guide them, or develop therapies that are specific for those who are more likely to develop this aspect of TSC than this aspect of TSC, and not treat everybody the same because they're not. And so we've started collecting biosamples. We've got over 300 biosamples collected now, and all of those are linked to clinical data in the natural history database, so that they've got their clinical path, what these patients have been through, together with DNA samples from them so they can ask genetic studies. And in many of the cases, we also have blood samples so that they may be able to look at plasma biomarkers, which are very important, as you might know, for drug development, to perhaps monitor disease progression, whether or not a drug is making a difference earlier than you might be able to get a clinical readout. And then the other program we added was a preclinical consortium. One of the things that came out of the workshop was a discussion of animal models, and there's no one animal model of TSC. We can't make a genetic mouse that looks like a person with TSC, especially when people with TSC are so different from person to person. So we have these different models that really model different aspects of the disease. And so we talked about which ones of those were the most well understood, the most reproducible and rigorous, and which ones were the most translatable to humans, which ones seemed to behave similarly. That is, that drugs that had some effect in humans also had some effect in the animals. And so the TS Alliance, with this input from the academic researchers, obtained licenses to those small number of models that seemed to be the most reproducible and rigorous. And now we've set up the running of those assays at a contract research organization so that researchers from anywhere, from academia, from whether they're an established lab or a young investigator, and from industry, can say, I've got this candidate drug that might be worth testing. I'd like to see it tested in these models. Well, there are a couple of options. One is they can they can agree that the data will be shared. So let's say it's a tool compound. It's not something a company is going to develop. It's been around for decades, but it might tell us something about the mechanism and how it works. Well, the TS Alliance can pay for that experiment if it's a good enough idea, and then we'll share the data with everybody in our consortium. If a company comes and says, I've got a new molecule, we're developing it for something over here, but we think it might work in TSC, but we can't share the data because it's still proprietary and we're developing it, fine. If you pay the costs and the license fees and a little bit of management costs for us for overseeing everything, you can run it and you can have the data. But it's in the same models for which all that other data will be publicly available. Some of it is, and some of it will be created because this is also very new. So it's become very attractive. We've had 6 companies sign up and say they would like to be a part of this and test molecules. And we're cranking along and been running experiments just over a year now. So it's putting these things together is the piece that the TS Alliance can do. It's taking a look at what can we do with our level of funding. We can't do everything, we can't develop drugs on our own, but what can we do that are important strategically to the TSC research community to help them do their research better, faster, and more effectively. And so that's why we've put these things into play. So I'd like to summarize just with some thoughts. And when I was thinking about this talk, how do I kind of put it together and turn it into maybe recommendations to summarize and share? One is the concept of communication. Keep that communication open or start it with people at NIH. They really want to help. They want to help make a difference. And if they can find a way, whether it's a small workshop or a strategic planning session, something like that, they will do it. Ask if NIH can sponsor a workshop. Maybe you come to them with the idea, this is what our researchers say would be really helpful, but we don't have the funds. Can you help us do that? Right? Maybe we'll kick in $1,000 for lunch so that we can pay lunch for 100 people or whatever it is. But can you pay the thousands of travel and hotel that it's going to take to get them together? Discuss ways with the CDC, the FDA, and there are probably other agencies that may be relevant to your disease that I haven't thought about. But discuss with those agencies, are there ways to partner with what they're already doing? They're probably not going to start up something from scratch in your disease, but is there a way you can partner with them and kind of piggyback onto something that they're doing anyway? Again, they want to get more bang out of what they're doing. They want to help more people. That's why they're at the CDC and the FDA, and so I think they'd be open to your suggestions. Consider whether one of the existing CDMRPs might be a fit for something that's relevant to your disease. Is your disease close to something that has an existing CDMRP? Maybe there's a way to kind of tie it together. I'll give you an example. Lymphangioliomyomatosis, or LAM, is a lung disease that's caused by spontaneous mutations in the TSC1 or TSC2 genes. So it happens that it really only affects the lungs, or maybe the lungs and kidney in some people, and they don't have everything else with TSC, but the biology is very related, and the TSCRP funds a lot of LAM research, and that's because it's all related. We're all going to learn from it because the pathway is so similar. And then finally, advocate for strong overall research funding. Without strong research funding, the NIH is going to be powerless. The FDA and the CDC aren't going to have the ability to help. The Department of Defense would have to cut its research spending. So you can always help at a very low cost for advocating to keep those dollars out there. So those are some thoughts I have based on our limited experience. John, please come up and share us a different point of view, and then we'll take some questions.
Okay, well, good afternoon, everybody. Thank you for coming to our session. We appreciate it. Hope that it is interesting for you and you pick up a few new ideas that you might be able to use. I am the chairman of the board of something called the California Institute for Regenerative Medicine. I don't know how many in the room are aware of this. Can I get a show of hands? Anybody in here hear of it? Okay, well, that's good. So, CIRM, as it's called, is a most unique animal created in 2004 in a ballot measure that was put on the presidential general election ballot as a result of hundreds of thousands of signatures signing a petition. And in California, you're able to do that in a way that if the ballot measure passes, whatever is the subject matter of that ballot measure becomes law of the state of California, regardless of what the constitutional officers or the legislature might think. Now, it just so happens that's how we came into being. The constitutional officers and the legislature have been very supportive of what we do, and what we do is we fund stem cell research in California. One of the unique aspects of this ballot measure, which formed the agency, is that it authorized a very large amount of money, $3 billion in state general obligation bond money to fund research, all in California. And the reason why it's all in California is when you issue bonds, they are secured by the general fund of the state of California, and the debt service is paid for by the taxpayers of California. So everything has to have a California nexus. Doesn't mean there can't be projects outside that have some sort of nexus, such as one of the clinical trials might be run at a university in California, and that component would be eligible for funding. But generally speaking, most what we do is fund work done here. Now, we are funding a whole lot of really cool stuff. We started funding in about 2007. We had some litigation that tied us up at the outset. But since then, we've put out about 2.5 of the $3 billion to fund research on 40 or so different currently incurable diseases or conditions, ranging from the most common, which would be cancer and heart disease, diabetes, neurological disorders, vision disorders, et cetera, all the way down to a host of rare or orphan diseases. We sort of don't have a preference. We have procedures where at regular intervals, grant applications come into us, and it can be on whatever. We don't have certain times we only entertain cancer applications and other times rare disease. It's whatever is ready to go can come and apply to us for funding. We're subject to very rigorous peer review. We have a group of stem cell scientists who are experts, all of which are outside of California, so you avoid any potential conflict situations, that evaluate these grants, and these people are unbelievably impressive. They really take their job seriously. The discussion, Steve, you would enjoy these, you sat through a million of similar sorts of things, is very detailed. The dedication is striking, and you end up getting projects that are recommended to our board that are very, very interesting. I'm going to start by, we always start every presentation with our mission, which is, as you see there, very simple: accelerating stem cell treatments to patients with unmet medical needs. So I'm going to start with a couple of examples of things we've funded, because they're pretty neat. So, we are, one of the things that's interesting about CIRM is we are not ideally looking for drugs that can be taken for a chronic condition for the rest of your life. Our goal is we're looking for cures. So those are very tough to come by, and they can take a long time. I mean, you go back and you look at how long it took Jonas Salk to develop a cure for polio. It started with the March of Dimes in the late 30s, and it wasn't until over 2 decades later that the polio vaccine became a reality and the disease was essentially cured. So, having said that, late last year, even though we've funded now, I think we've had about 700 grants since we started, we had our first 2 cures, and these are pretty neat. Both of these are rare to fairly rare. The little girl on the left, Evie, is one of our cover girls. She has SCID, better known as bubble baby disease, for those of you who are familiar with that colloquial term. which is a mutation in your blood-forming stem cell that causes you to have effectively no immune system. So you have to live quarantined from day one. It's a terrible existence, and if you catch anything, it can kill you. So, by the way, both of these diseases were out of the same lab, a UCLA lab. So the other disease, which is just, since it's kind of hard to pronounce, we call it CGD, is similarly a mutation, that one typically found on the X chromosome, which is why it's more commonly seen in males, is also one that leads to deficiencies in the immune system and makes you subject to being basically sick all the time and ultimately affects organs and is a very bad deal. So what the scientists at UCLA did was really interesting. You've heard or know that it's now possible to map your entire human genome, which is all of your DNA. And when you do that, you can actually pinpoint in your DNA where the mutation is that's causing a particular condition. And once you've done that, in recent years, they've developed a technique to go in and gene edit out the mutated DNA base pairs, if you remember base pairs from your high school biology, and splice back in the correct sequence. Well, what they did, we'll take Evie for example, is they took her blood-forming stem cells, which are normally found in your bone marrow, and that's what produces your bloodstream and all the components. And they pinpointed the mutations in her DNA. They went in, they excised them out, and they spliced in the right sequence, and they put those blood-forming stem cells back in her bone marrow, and then she started cranking out blood that had a full immune system. And in very short order, that overtook the problematic cells that were in the blood, and she and 32 other kids who lived in perpetual quarantine are now off any medication. They are in school and subject to getting anything, and their parents don't care anymore. So this is an example of the power of gene therapy and stem cell therapy. And similarly, Brendan now had a similar process done for his blood-forming stem cells, and he too now has a fully functional immune system and doesn't get sick anymore. And so you see these people and their families, and it just gives you a real feel for the promise of what we're dealing with. Jake, all these stories are awful. This was one very sad, very awful story where he was about to be a football player on scholarship up north, and had a swimming accident that left him paralyzed. And at the time, he had a great deal of trouble moving his arms or legs. And he went into a trial with a company that we're funding that's using embryonic stem cells to treat, or hopefully to treat, spinal cord injury. And he has been on this now for a number of months. And if you were to see what he looked like before, where he literally couldn't do anything, he now can lift weights above his head. Still, the legs are still paralyzed, but he's seen real improvement in his arms and his hands. Long way to go, but again, it's suggestive of the potential for stem cell treatment. The company, anybody who wants to look them up, is called Asterias, A-S-T-E-R-I-A-S. This was a fellow who had cancer, solid tumor cancer. Now, you guys have all been seeing in the papers recently a lot written about what they call immunotherapy, which is you turbocharge the T cells in your immune system so that they can recognize cancer cells and go after and destroy them. And that's something that's been used very successful results, particularly in the blood cancers. But it has yet to really prove to work in solid tumor cancers. But there's some advances in this regard. Carl was somebody who had a solid tumor, and the technique in the project that we're funding on this one was there's a gene that sits on the outside of certain blood cells that end up getting out of whack and becoming cancerous, that sends out, from the gene comes a protein that emanates from it, and that protein will have the effect of creating an invisibility shield around this cancer cell. Sort of like, if you remember from your Star Wars days, the Dark Star had this thing around it. And there's a very scientific term for this phenomenon. It's called the "don't eat me" effect. Seriously. And so the question was, is there a way to neutralize that gene in a way that knocks out the Death Star shield? And there's work that was done at Stanford that developed something called a monoclonal antibody, which you've heard the term, not really worth defining what it is, but it's a biologic treatment that goes in and does things in the body. And in this particular case, it was developed to target that very gene that gives rise to the protein that causes the shield. And in animal models, lo and behold, this homes in and completely neutralizes that gene. And they got some very compelling preclinical data. Whenever you hear preclinical, as Steve was talking, preclinical means work on animals that you use to advance your case to the FDA, that they should permit you to then go to the FDA and do human clinical trials. Anyway, so that is in early stage clinical trials. You know, it's science. We don't know if it's going to work or not, but if it does, it has the potential to apply to many solid tumor cancers and would be a true grand slam. This is a great story. So the disease is another terrible disease, but it's a great story as it's playing out. Rosie has something called retinitis pigmentosa, which is a degeneration of cells at the back of your retina that causes a progressive narrowing of your line of sight, almost in spherical fashion, where it just gets smaller and smaller and smaller until ultimately you can't see. There's a local scientist here at UC Irvine is working on a treatment where you take embryonic stem cells and you program them to become something called retinal pigment epithelial cells, or RPEs. You can then put on almost imagine like a cookie platter or cookie, whatever you put in the oven, and thank you, yes. And there's an incision in the back of your eye where you can then, you put these things all across that, and you put that in the incision, and that grafts to the retina, these cells, as they mature. And the idea is that will hopefully restore sight. Well, she's in clinical trials on this, and she came to one of our board meetings. She can now actually detect, she can see shapes, she can see forms, she can see colors. She actually can make out faces. And as you see, you got to see her kids' faces for the first time ever. Her husband jokes that now she can see his face, and he's not sure that's a great thing. But again, this is another example of the potential of stem cell therapy. Okay, so having just given you a little bit of a taste, so at CIRM, when we started, we funded a bunch of stuff. We then underwent a process to improve our different protocols and how we do things, and we coined that very novelly, CIRM 2.0. And we have a bunch of goals. And the goals, as articulated by the board, are this was started in 2015, was to have 50 new clinical trials by 2020. I can see we're up to 35. 50, well, I'm not going to go through all this stuff. Some of these things are sort of in-house jargon. That's the big one, the clinical trials, and we have a lot of things backed up behind that, those 35, and they cover, as I said, all sorts of different things, including the things that I just talked about in more detail. But the takeaway from this slide is there's a whole lot of stuff being done in California. By the wisdom of the voters and the funding we have, California is really sort of overwhelmingly the largest center for stem cell research in the country, and that makes it for a very exciting time. We live in very interesting times where the pace of biological and medical research is exponential, and things are happening. And when this period is written about in history decades from now, this will be viewed as a seminal time in the history of science. This is something for those of you who are either involved with stem cell trials or are looking to be involved in stem cell trials. We have this thing we call alpha stem cell clinics, which basically gives you soup to nuts if you need to be part of a clinical trial involved in a particular condition. We have 3 of these, City of Hope, UCI, UCLA, sort of a hybrid, and UC San Diego. We're going to be adding 2 more at our board meeting in late September. So we have this network which collaborates with each other. One of the great things is, if you've ever been a part of trying to get into trials, there's this thing called IRB review, which is always, it's a sort of by the institution that's doing the trial, and they have their own idiosyncrasies, and it takes a long time. This network has a network-wide IRB, so if you get through that process, it applies to any sort of trial aspect that you would be involved in at any of the facilities. No, we don't know of any other such network like this. This is something that is not just for CIRM-funded projects. It's, in fact, the majority of the projects that are undertaking clinical trials right now are not CIRM-funded projects, so they can be from anywhere. So anybody who's interested in learning about the clinical trial experience, you should let me know. This just is a breakdown on our what we're doing the clinical trials on, and you can see on the right the number of phase 1, 2, and 3. We tend to favor the earlier parts of the trial. We were set up to fund what they call the Valley of Death, which sounds like a disease term, but is really an economic term, and what it means is we're a new field, we're maturing now, we're kind of going into midlife, but the pharma companies don't like spending R&D on new fields. They want more certainty. So, but for us and others like us, nobody would fund the early research, and that's the Valley of Death. It's sort of an economic thing driven by the fact that the big money guys at the end of the rainbow are waiting. They want to see, and you're starting to see them come. With projects like what I described, there's more and more getting into this. More and more money is going in through equity raises into companies that are spun off of academic centers that we're funding research at, et cetera. On the left, you've got the description of the different types of indications that we're funding. It sort of speaks for itself. Okay, patient advocate role. We're huge on patient advocates. We're about patients. You saw that mission statement. Patients are involved in a whole bunch of ways. When this was originally put on the ballot, a host of disease foundations and patients that are part of it were very instrumental in helping get the word out on the ballot measure and getting it passed. When it was formed, we have a kind of large 29-member board made up of the deans of medical schools, heads of research institutions, biotech execs, and 10 of the 29 are patient advocates. representing different diseases and conditions. And they have a big role in the board. They also sit in on the peer review, similar to what Steve was saying, and have direct input into that. They also have, and this is something that's I think is a particularly cool feature of our funding. If you go to the NIH, you get a grant. Obviously, that's great. They're hard to come by. I think the success rates these days are like 8%. And hopefully the draconian cuts threatened by the new administration don't come to pass, or there will be even less funding available. It seems to have died down a bit because Congress made it clear that they didn't want to cut NIH funding. But when you get these grants from the NIH, they basically say, good luck. We don't do that. We actively manage. We stay in touch with the investigators. We insist on milestones being met to get payments as they go along, because we give some really big grants. NIH, the sort of bread and butter grants, their R01 grants are like 380,000, something like that. Our largest awards are 20 million. So for us to put money out, we want to make sure that whoever's got it is doing what they're supposed to be doing. Well, one of the things we do, is the point of this, is this CAP thing in the middle, which stands for Clinical Advisory Panel. So if you're in a clinical trial, say it takes 4 years, we impanel a group of experts in the condition to come and meet with you on a regular basis, not to criticize, but to hear where you are and to affirmatively look to improve what you're doing, to tweak it in a positive way that'll give you more chance of it succeeding. And these things are phenomenal. The scientists love that they're there. They consist of scientists who are experts in the field, not involved in the project, and a patient advocate who gives perspective and thoughts. And then aside from that, we also, we're in constant contact with all the major disease foundations of the diseases that we fund research on. They give us input. They're involved in all sorts of ways in events we do, and have a lot of chance to suggest direction and give us sort of real life feedback as to whether what we're doing is indeed valuable, et cetera. So patients and patient advocates are very prominent in our universe. FDA, Steve mentioned, our field is new, and anytime you have a new field, the FDA is not quick to develop the procedures they're going to implement to review you, because they're as they always are when you get into new stuff, they are very cautious and standoffish, but they are now starting to get more and more comfortable with what's going on. We worked very closely with them. We had the 21st Century Cures Act that was passed towards the tail end of the Obama administration, and there is a whole part of that now that's dedicated to regenerative medicine, stem cell stuff. And we are sort of now partners with the FDA in helping to give guidance on the various things they should consider as they receive this, what's going to be an avalanche of stem cell related clinical trial requests to them as things move further and further down the research continuum. So sort of stay tuned on that. This is an evolving story, but my main message to you is we're as all over it as we can be, and as the largest funder of stem cell research in the world, we have at least a modest amount of credibility back there in those discussions. I think this is our last page. We have all sorts of ways to check up on us. I would say to you, if you are, as everybody here is, involved in dealing with a rare disease or other, we're very interested in funding research into rare diseases. We have a lot of them. And not infrequently, what we're able to do is a material boost to the whole effort, because it's hard to get research dollars these days. So I would recommend that even if you're out of state, if you're involved in with a scientist who's doing research, and particularly if it's sort of getting anywhere near the clinical trial phase, and it's got to have not only the California Nexus, it has to have some sort of regenerative medicine hook, right? So it's got to be something that has to do with degeneration of something, or cancer stem cells, or some sort of thing that brings it within our universe. It can't be like, what's the next drug going to be for such and such disease, because that's not us. We are cellular therapy. But that covers a lot of universe. So I would encourage you, there at the bottom, cerm.ca.gov, you can contact people through that and have your scientists that you're working with do that. And we hope that, that we can see a number of you apply for funding. Obviously, not everything gets funded. It's got to pass the peer reviewers, and that's not easy, but a lot of stuff does. As I say, $2.5 billion worth of grants at this point. So I think that concludes what I've got. So thank you for listening. And Steve, do you want to come up here? And I think we're just going to sit here if you have any questions.
Thank you both. That was great. I actually have a question about the CDMRP. I don't know if you can tell me, we've been working with a lobbyist that is helping us kind of navigate this process. Have you seen, I know you're already in, obviously, have you seen that there's been a reduction over the past several years in new programs that are initiated through this CDMRP?
Yes. Yeah, I haven't seen new ones added recently. It's pretty stable in terms of the programs. There are a couple that have kind of rotated off, but I can't remember the last one that was added. I might just not be aware, but it's not very common.
Any other questions?
Regarding CERM, do you have to, in order to apply for a grant, do you have to have a research project proposal ready to go, or do you fund foundations who then fund research projects?
So the question was, do we need a project to be the subject matter of a grant application, or can we just fund a disease foundation that can deploy it, presumably however they want? The answer is the former. We need to have a very well thought out project description, and we fund all the way from the earliest basic research all the way through the clinical trials and everything in between. So generally speaking, if you're a very early project, you need to give rationale for why you think it's a worthwhile project. It could be very early where you have almost no data, but you still need to make your case for why you think this is going to achieve whatever it is you think. If you get further along in that spectrum, you need to provide some very solid data to back up your idea as to why the project should proceed, and that the further into it you go, the more data you have, and that data is absolutely the subject matter of the peer reviewers, and so that what they look at. So we don't have a mechanism for just funding. That's a great question. I actually never had that one. That's a very good question, but it's very project specific. Is the answer.
And if the foundation is located or headquartered in California, it's an international foundation, headquartered in California, but none of the research is taking place in California, would that be considered?
So you need to have when I say a nexus, it has to generally be that something's happening in California. And that can cover a range of things. It could be that the clinical trials are run at, say, one of our Alpha Clinic sites. These projects all have a big component of cell manufacturing, where you have to be able to have enough stuff to treat, and it's not easy. Very non-trivial process. You could have the manufacturing plant in California, and that could be the subject matter of an application, but it can't just be that there's like an office in California, but everything else is done outside.
Yeah.
So, yeah.
Okay, thank you.
But you can, there are ways to make things happen in California to make yourself eligible.
Yeah, hi. I want to say thank you. I'm a stem cell therapy patient myself, and I could say it saved my life. So thank you for what you're doing. And where can other patients find out about the stem cell projects that you're funding so that they can become a part of them? Do you have a master list of that?
Yes, so that website I gave you, cirm.ca.gov, has absolutely everything you need to know. And it has a complete list and breakdown of projects according to indication, where they are, sort of what the subject matter is of the grant. And if you go through and look at that and that generates additional questions, you should absolutely just call and ask everything, because our people are we're an unusual state agency. There are I think about 45 of us now, and I'd say probably at least over half are MDs and PhDs, and they're people who are very attuned to the research world and can help answer any conceivable question anybody would have. Yes, sir.
Thank you. My name is Frederick Soremi, and I represent, as a patient, a disease called FCS, familial chylomicronemia syndrome. One of the effects is mental fog, so that's why I'm not maybe coherent sometimes. You referred to, most of your questions were for scientific funding. We are a small organization as a foundation to advocate education and passing the word about our disease. Do you fund those to be able to propagate that information?
We have some educational programs, but they're a little different from that. Our programs are aimed at generating a human pipeline for the industry. So we have very active college and postgraduate programs that we fund, and we also have high school programs, which are among my most favorite, because these kids will go into like a 6-week summer thing and they don't know the first word any of the vernacular, and they come out after 6 weeks and they sound like PhDs. It's very impressive, kind of scary. Glad that we're not back competing with those guys now, that's for sure. But in terms of funding for education, we don't have that, but that's an interesting idea. So I thank you for raising that. We'll think about that.
Next item on your agenda for the board?
I'm not sure if it's the next item, but we'll definitely, I'll take that back to and again, everything we do needs to have some sort of cellular therapy element to it. So there are lots of very serious conditions out there that aren't of the sorts of things that we treat, and we've got to be very careful about that to stay within the mandate of the proposition.
I'm here as a patient advocate for primary biliary cholangitis. We have research out of UC Davis with a mouse model, and getting very close to cracking the nut, right? As a patient group working with UC Davis directly, we're often called to come and donate warm blood, because that's what they need to break down for their research. It can't be stored, it can't get cold, it has to be warm, that fresh. There are 50 of us that live that close. I just happen to be one of them. As we work through that process with this particular researcher, who's kind of the father of our disease research, we've funded a lot of his preliminary research through our group. He now gets NIH funding. The cellular portion of that T cells that affects our liver is known. We can duplicate a mouse model that mimics the disease. So we're very, very close to, as I said, cracking the nut. If you can turn it on, you can turn it off, ostensibly. Is that a level of research that would be of interest to your organization with a specific goal in mind to reach that level? Because we're kind of stuck in that. Not quite there yet, but there.
So we fund a lot of work at UC Davis. Jan Nolte's group up there is a great group doing some terrific work. They know, all the people up there know sort of everything about us and what we're looking for and the process and everything else. So what I would suggest is have your scientist, because there's some elements of what you described which could, I can't say definitively, be in the right subject matter, but you should have them, he or she, talk to Jan and just sort of say, is this something that we should be looking to apply for? So thank you for that question.
My name's Romy. I am diagnosed with a rare neuromuscular disorder, LEMS, Lambert-Eaton myasthenia syndrome. And I wanted, even though this meeting doesn't really pertain to that necessarily, I am from the Philadelphia area, and I did see on the news last week that CHOP and University of Pennsylvania have come up with a gene therapy they're trying it with young children right now that have a type of leukemia. I'm not sure if you heard about this revelation. And they tried it with this 5-year-old girl, and she got really sick, but they took her cells out. They kind of like what you were talking about, changed the way the cells work, put it back into her system, and now she's 100% remission. And so with that being said, I know you talk about California and there's a lot of research, going on in California. Do you guys share information? Like if this is working for somebody and helps put somebody with a certain kind of leukemia in remission, they're doing it with kids first, instead of adults. Where does the future hold with you guys sharing information and being able to use that kind of success and bring it to California, or is that already being done and you have meetings, to discuss what you're doing, and share information?
Well, a couple things. One is, that's a great question also. The people who are in the field with respect to your specific condition, generally speaking, it's a finite universe of sort of top flight researchers, and they know each other, and they talk, and they keep each other up to speed in what they're doing. It's tricky because all the stuff that comes out of the academic institutions or the scientific institutes all has intellectual property issues attached to it. So the idea of, it'd be great if you could just have everybody shared everything and nobody cared about, who owns what or who materially benefits from what or whatever. Unfortunately, that's not the world we live in. But with respect to the sharing of that stuff, I don't know in California if there are experts. I'm sure there must be some people doing research on that, but they would know whoever is at CHOP or Penn. That field is a very hot one, and so I think that you would see that. But if your researcher or whatever again has I don't know how far along the research is at this point. It sounds like quite, based on what you were saying, but these things all need clinical trial sites, and that's how you can get sort of hooked into California. And I would encourage whoever you're dealing with to see if there's a way to reach out to a colleague they have out at, you know, whatever, UC Irvine or USC or whatever, and see if there's a way to collaborate.
Well, I just think, you know, also with my particular disease, I was misdiagnosed several times before I was diagnosed, and my doctor told me in Philadelphia, I want nothing to do with you because you're too rare, and it's a lot of paperwork, so, oh, excuse me, for clinical trial, oh my goodness. And he basically, you know, what I found through years of, now I fly to Phoenix to see a Dr. Barrows from Philadelphia, because I will not, but I got Jefferson Hospital up on the access road for the Lansing folks. What I find is that a lot of doctors won't see pharmaceutical companies, or like are really closed-minded, or if they have an idea in their mind, like, for example, Jefferson Hospital, they wouldn't see my pharmaceutical company. They just wouldn't see them. So I went in as a patient, and as a left diagnosis to see the doctor, and when I saw the doctor, I said, watch this, and I walked up and down the hallway, and he started to cry. And he's like, I have 4 LEMS patients, oh my God, you know, and it wasn't until that moment, till he saw me actually walk, that he had the pharmacy come in the next week and get him on the access program. So my personal feeling is sometimes, you know, you listen to your doctors, but sometimes it's good to reach out. I mean, I had to struggle, and a lot of it, I think, you know, doctors need to embrace education.
Yeah, well, I would encourage, there's a endless amount of information off the internet, who's doing what, and I would always suggest that you thoroughly research what's out there, because, and by the way, not all of it's reputable. Really the case in stem cells. I mean, one of the things we deal with are these sort of stem cell clinics that tout doing this and that and say they'll cure whatever ails you. And both in the U.S. and abroad, we call it stem cell tourism, and you can really have some problems. And we had that instance that was in the news 2 or 3 months ago, these women who went down to Florida. There was a stem cell guy who supposedly had whatever they needed for their particular eye condition, which was bad, but not, you know, terribly advanced, and all of them became partially or fully blind as a result of this treatment. I mean, it was really bad. So you got to be really on top of what you're looking at and make sure that it's something that's being very thoroughly vetted by authorities and regulators and everything else, because otherwise you can be both harmed and completely taken advantage of. There's a lot of snake oil guys out there that will say anything to patients to get money, and it's really harmful, so you got to be very careful.
So that concludes our session today. We're going to take a 10-minute break, but thank you, Steve and Jonathan, and please join me in thanking them again. So at this time, you can jump onto the mobile app and take our brief survey on this session, and you can enjoy our afternoon break. Our next breakout session will begin in 15 minutes, and thank you for attending. Enjoy the rest of your afternoon.